log in and claim credit for this activity online at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to one prescribed credit by the AAFP, and physicians should claim only the credit commensurate with the extent of their participation in the activity. Next slide, please. All right, these grand rounds will address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Next slide. All right, and now Dr. Duong will introduce our speakers today.
Hello, everyone, and it's my privilege to introduce Dr. Delgado and Dr. Duong. Dr. Luis Delgado completed his pharmacy school education at the University of Incarnate Word Fikes School of Pharmacy, and he completed his postgraduate year one experience at the VA Caribbean Healthcare System in San Juan, Puerto Rico. His clinical interests are focused in outpatient nephrology and cardiology. Dr. Stephen Duong, he completed his pharmacy school education at the University of Texas at Austin College of Pharmacy and completed his postgraduate year one experience at Baptist Hospitals of Southeast Texas in Beaumont, Texas. And his clinical interests are focused in outpatient psychiatry and HIV medicine. So both speakers are currently postgraduate year two ambulatory care pharmacy residents here working with us at the University Health System. So thank you for doing this, Dr. Delgado and Dr. Duong, and I'll pass it over to you guys.
Thank you so much for the introduction, Dr. Duong. Again, my name is Dr. Stephen Duong, and today I have with me Dr. Luis Delgado. We are very, very excited to share with you our topic for today, which is called Brewing Post-MI Success with Beta Blockers. Here are today's mission objectives. By the end of today's presentation, you should be able to describe the physiological rationale for beta blocker therapy for myocardial infarction, review current guideline recommendations and their supporting evidence in managing acute and chronic coronary syndromes, evaluate recent primary literature regarding the appropriate duration of post-myocardial infarction beta blocker therapy, and finally, we're going to have you formulate an appropriate treatment regimen for managing beta blocker therapy post-myocardial infarction based on available evidence and patient-centered considerations.
Alrighty. First, let's take a look at the mayor of Townsville. This is a 65-year-old male presenting with chest pain that started an hour ago, radiating to his left arm. Pertinent medical history is significant for hypertension, type 2 diabetes mellitus, hyperlipidemia, and no history of myocardial infarction. He presents with a blood pressure of 148/92, a heart rate of 86 beats per minute, a respiratory rate of 18 breaths per minute. His oxygen saturation is 98% room air. His home medications are lisinopril 10 milligrams daily, atorvastatin 40 milligrams daily, and metformin 1,000 milligrams daily. During his hospital admission, the medical team reports the following: an ST segment elevation on EKG, high sensitivity troponin 56 nanograms per liter, a BMP of 60. Echocardiogram findings reveal a left ventricular ejection fraction of 55% with no significant wall motion abnormalities. Results of cardiac observation reveal that there's no flow limiting stenosis in the left main or the left anterior descending. The left with placement in his right coronary artery. He is stabilized and home medications and guideline-directed medical therapy are initiated, including dual antiplatelet therapy, aspirin with ticagrelor, and metoprolol. Prompts the inpatient pharmacy team to review the mayor's chart and preparation for discharge. Revisiting the mayor's case, I have a question to ask. The mayor of Townsville was admitted for STEMI and started on GDMT. However, he does not want to take all of his medications forever. How long would you recommend continuing metoprolol for our patients? A, 6 months, B, 1 year, C, indefinitely, or D, we don't know. Let's review relevant literature.
And that's some context as to what's going on before we dive into the literature. Let's talk a little bit about acute coronary syndrome, also known as ACS. This is a really broad term used to describe the occlusion of a blood flow into the coronary artery, thus preventing blood from reaching to the heart. They are broken down into three subtypes of acute coronary syndromes, and our focus for today is going to be primarily towards our non-ST elevated myocardial infarction patients and our ST elevated myocardial infarction patients. However, stable angina is something. Coronary artery disease is the leading cause of morbidity and mortality worldwide, and it has been estimated that there's been a 1.2 million individuals in the United States that have been hospitalized annually, with 30% of them being STEMI patients and 70% of them being NSTEMI patients. To further break it down of what occurs in the body, let's talk about the pathophysiology. First, we look at all the comorbidities that a patient may present with. We are going to discuss a little bit further when we're talking about the risk factors that may predispose patients to experiencing this. So we take all the comorbidities into consideration, which thus lead to inflammation and deposition of cholesterol over time. There's going to be some plaque buildup, and then eventually there's going to be some rupture or erosion, thus subsequently causing decreased blood flow to the heart musculature and leading to occlusion and acute ischemia. The risk factors that we were discussing previously that affect our comorbidities include smoking, hypertension, dyslipidemia, diabetes, obesity, male sex, psychosocial stress, genetic factors, as well as family history, as well as physical inactivity. As we can see from the risk factors here, these are a lot of the disease states that we see in the primary care setting as well. So it's always good to keep in mind to make sure that we are assessing everything and holistically for our patients. For patients that undergo or experience any sort of acute coronary syndrome, clinical presentation may vary from patient to patient. However, one global symptom that patients may experience is as if an elephant or a very, very heavy feeling is coming down on their chest. So it feels like they're having a lot of chest pain. However, other symptoms that they may present with include anxiety, irregular heartbeat, dizziness or fainting, fatigue, nausea, vomiting, cold sweat, shortness of breath, upper body pain, chest discomfort, and indigestion. And for diagnosis and differentiation, you may or may not be very, very familiar with this more than Luis or I, but we'll talk a little bit about the differentiation between our unstable angina patients, our NSTEMI and STEMI patients. First, we look at the electrocardiogram and differentiate it between our STEMI and NSTEMI patients. With our STEMI patients, we do see a lot of ST elevations, whereas our NSTEMI patients, we may see ST depression and T inversions. What sets these aside from unstable angina is that in our patients with unstable angina, we look at a different biomarker called troponins. At University Health, we use our highly sensitive troponins, and we do trend them and make sure that they do go down eventually. But it is something that we kind of use to differentiate between our unstable angina patients, which should be very minimal to none, versus our STEMI and STEMI patients. Well, this brings us to our first knowledge check question, just to make sure everyone's been staying awake. Which of the following are patient factors that increase the likelihood of occlusion and acute ischemia? A, uncontrolled A1C, B, current smoking, C, chronic high blood pressure, or D, all of the above? I see a D. That is correct. Like I was discussing previously, all these comorbidities may predispose patients and lead them to eventually experience acute coronary syndrome.
Moving on to the management of post-myocardial infarction. We cannot discuss the management without first talking about the goals of therapy, and I will introduce you to those now. When reviewing therapy goals, it is essential to emphasize the management of comorbidities to prevent subsequent cardiovascular events. With consistent follow-up visits and adequate patient engagement, we must then focus on sustaining risk factor treatment targets such as blood pressure control, lipid management, and diabetes management, among others. It is important, however, to recognize the importance of optimal pharmacotherapy. But before we talk about pharmacotherapy, I'd like to remind you of some non-pharmacotherapy options. Non-pharmacotherapy options include smoking cessation, dietary changes, physical activity, cardiac rehabilitation, and the management of comorbidities and risk factors that my colleague Stephen mentioned earlier. And of course, we can't continue this conversation without talking about our pharmacotherapy. Our post-myocardial infarction therapies include antiplatelet therapy, angiotensin-converting enzyme inhibitors, and angiotensin II receptor blockers, beta blockers, and high-intensity statins. Our antiplatelet therapies carry a class 1 recommendation, and they prevent thromboembolic events and recurrent myocardial infarction. They confer strong mortality benefit. Our ACE inhibitors and ARBs carry a class 1 and 2A recommendation, and they reduce mortality, hospitalizations, and major adverse cardiovascular events. Our beta blockers carry a class 1 and 2A recommendation, and they decrease myocardial ischemia and reinfarction. Our high-intensity statins carry a class 1 recommendation, and they reduce the rate of recurrent myocardial infarction, coronary heart disease mortality, the need for revascularization, and stroke. For our presentation, however, let's discuss beta blocker therapy a bit more in detail. First, discuss their mechanism of action. Beta blockers suppress beta-1 adrenergic activation, thereby decreasing heart rate and contractility, and subsequently reducing sympathetic stimulation on the heart. They also reduce myocardial oxygen demand, helping to minimize angina and reduce infarct size. They also increase coronary blood flow by increasing diastolic filling time, which enhances coronary perfusion to ischemic myocardial tissue. They also protect against transmembrane potassium shifts by blocking beta-2 receptor activation, which then reduces catecholamine-induced potassium efflux, helping to prevent hypokalemia. And of course, we can't end our beta blocker conversation without summarizing their pros and their cons. The pros of beta blocker use are that they decrease myocardial oxygen demand, they minimize left ventricular remodeling, they reduce arrhythmias, they improve the ischemic threshold, and decrease cardiac death and reinfarction. Some of the cons of beta blocker use are that they may come with some side effects, reduce exercise tolerance, masking of hypoglycemic events, and they may increase pill burden if they're not necessary. With this in mind, let's move on to a quick knowledge check. This brings us to knowledge check number 2. What is the primary rationale for beta blocker therapy post myocardial infarction? A, reduce myocardial oxygen demand. B, increases contractility. C, promotes plaque regression. Or D, inhibits platelet aggregation. Alrighty, and this one's going to be A. They do reduce myocardial oxygen demand. Thank you all.
So now we know a little bit about how our beta blockers work in our body and how it affects in our post-myocardial infarction patients. Let's dive in a little bit deeper into the history of beta blocker use in our post-myocardial patients. So back in the 1960s, there were some evidence from trials that were very insufficient to recommend beta blockade as a standard of therapy following an MI. At this time, it is of note that no antithrombotics were used in the 60s. As we moved closer to the 1980s, we did look at different trials, and some beta blockers did demonstrate mortality reduction in the acute phase post-myocardial infarction. Some of these beta blockers may include propranolol, metoprolol, atenolol, and timolol. We did start seeing some of these benefits, and of all these studies, there's one study that's still being referenced in the most recent STEMI and NSTEMI guidelines to support recommendations, which we'll discuss in just a bit. As we move closer to the 90s and also the 2000s, we're finally seeing evaluating beta blockers in the setting of acute myocardial infarction and treatment with reperfusion therapy. Antithrombotics were started to use like after the 80s, and during the 1990s and 2000s, we're looking at reperfusion therapy, which typically includes revascularization strategies like our percutaneous interventions, as well as our dual antiplatelet therapy and aggressive lipid-lowering therapy with our statins. As we move closer to the 2010s, we're seeing beta blocker use in patients undergoing PCI. And based on the follow-up times for duration of a beta blocker use, there's still a lack of data showing benefit in uncomplicated patients after 1 year of beta blocker therapy. So this next slide is a huge conglomerate of a lot of the studies that have been happening over the years. These are some key beta blocker trials, and they're all randomized controlled trials, starting from the 60s all the way to 2005. Just to summarize briefly, as we were discussing previously, there was some very minimal evidence that beta blockers were effective around the 60s, but the first study that they did see where there was some sort of evidence was from Snow and colleagues. As we progressed through the 80s, there were quite a few notable studies that were done in Norway. There's also Hjalmarsson and colleagues, which is still the study that was referenced in the 2013 and 2014 NSTEMI STEMI guidelines. And then we also have the beta blocker heart attack study group in 1981. We did see that there is lower risk of death in all these patients. As we progress towards the 2000s, there were some notable trials, include the Capricorn trial and also the Commit trial. In the Capricorn trial, we did see that carvedilol did come with a lower associated risk of all-cause death, cardiovascular death, and non-fatal myocardial infarction. And then we also look at the Commit trial, where we did see that metoprolol was associated with increased risk of CV shock, also especially those at high risk for developing shock. Something to note for all of these trials, as we can see, is that the duration of treatment was highly variable. Most of them did have very, very short periods of study, and were only studied mostly in the acute phase of the myocardial infarction during the onset of symptoms. This brings us to our current guideline recommendations. So of note, back in 2013, in the STEMI guidelines, beta blockers should be continued during and after hospitalization for all patients with STEMI and with no contraindications to their use. This was rated as a Class 1 recommendation. In 2014, the American College of Cardiology, as well as the American Heart Association and STEMI guidelines, did say that it's reasonable to continue beta blocker therapy in patients with normal left ventricular function and non-STEMI patients. This was a 2A recommendation. Of note, as I was discussing before, the 2013 and 2014 guidelines did not really specify timeline and duration of the beta blocker therapy. However, they did cite certain trials that were used before, and if we were really taking a deep dive into it, the previous studies that they did reference were before percutaneous coronary interventions were utilized as reperfusion therapy. This brings us to the 2023 ACC/AHA chronic coronary disease guidelines. In this guideline, it mentions in patients with CCD who were initiated on beta blocker therapy for previous myocardial infarction without a history of or current ejection fraction less than or equal to 50%, angina, arrhythmias, or uncontrolled hypertension, it may be reasonable to reassess the indication for long-term use of beta blocker therapy for reducing major adverse cardiovascular events. Long-term was defined as greater than 1 year. This was a 2B recommendation. And something just to also reference, there's also the 2023 European Society of Cardiology ACS guidelines. They did mention that their routine beta blockers for all ACS patients, regardless of ejection fraction, should be considered. This was also a 2A recommendation. When we're looking at the evaluation of the literature, there are still some studies to this day that are in support of discontinuing beta blockers after a certain time period versus some with just continuing beta blocker therapy. With the study of Kim and colleagues back in 2020, this was a retrospective cohort study in patients without heart failure 1 year after coronary revascularization for acute myocardial infarction. So here are some of the outcomes that happened before and after 1 year after index of myocardial infarction. So we did see that at first glance, the results of the study were that beta blocker therapy for those with on it for at least a year or more has significantly lower risk of all-cause death. However, as the more we dive in, we look at the baseline characteristics of the other GDMT that were used in this study. So, as we delve more and deeper into all of this, we can draw more attention to the other mortality reducing agents and see there is a stark difference in usage at baseline compared to 1 year after myocardial infarction. One thing to note is that there's a disproportionate amounts of patients 1 year after myocardial infarction when we're comparing the two study groups. Some of the limitations of this study were that it did not include information on ejection fraction. Long-term beta blocker therapy patients had less severe risk profiles than the discontinuation group. There was a huge difference in usage of other mortality reducing agents. For example, when we're comparing our patients with less than 1 year of therapy for our statins, we did see that it's pretty much about the same from those that were on it for a year or more and those that were on it for less than a year. However, 1 year after myocardial infarction, we did see that those that were on it for less than a year, that there were less that were on statins compared to those 1 year or more. So 68.6% compared to 95. So something for us to note as well. And all of this brings us to the current use of our beta blockers, and this is based on the 2023 Chronic Coronary Diseases Guideline. So, just to break it down, if a patient has an ejection fraction less than 40%, with or without a previous MI, treatment with beta blockers is recommended to reduce the risk of future major adverse cardiovascular events, including cardiovascular death. If a patient has an ejection fraction of less than 50%, using metoprolol succinate, carvedilol, or bisoprolol with titration to target doses is recommended over other beta blockers. Now comes the gray area. If a patient has a history of myocardial infarction with or without an ejection fraction of less than or equal to 50%, angina, arrhythmias, or uncontrolled hypertension, we must reassess the long-term use of beta blocker therapy for reducing major adverse cardiovascular events. Again, this is a class 2B recommendation. And finally, another group of our patients is if a patient doesn't have any history of myocardial infarction or an ejection fraction less than 50%, less than or equal to 50%, beta blocker therapy is not beneficial for reducing major adverse cardiovascular events without another primary indication for beta blocker therapy. So this leads us to the clinical question of the day. How long should beta blockers be used in patients post-MI? If you feel like you want to answer this now, you can just put your guesses in the chat, and we'll definitely discuss this as we go through the different clinical trials. So we are going to be reviewing 3 clinical trials for today. We have had some help from the Powerpuff Girls. So we have Bubbles, Blossom, and Buttercup. Each of them brought a different study for us to review as a group, and we will be able to find some information and have better insight on how to better treat the patient for today, which is the mayor. First, let's talk about a study called Beta Blockers after myocardial infarction and preserved ejection fraction. This is also known as the Reduce AMI trial by Indigen and colleagues. To break it down, the objective of the study was to investigate whether long-term beta blocker treatment would decrease all-cause death or new myocardial infarction compared to those without any beta blocker therapy. The way how the trial was designed was that it was a registry-based, open-label, multi-center, randomized controlled trial spanning between Sweden as well as in other areas in New Zealand. The patient population that was focused was that there were about 5,020 patients that were enrolled. Of those patients, they had to have a post-MI ejection fraction of 50% or greater, as well as noted obstructive coronary artery disease. The primary outcome of this trial was the composite of death from any cause of new myocardial infarction. As we look into the baseline characteristics of the patients that were studied, the majority of them are around 65 years old, and a huge proportion of them were men. A small proportion, 35.2%, had a STEMI. However, 95.5% didn't undergo PCI. Some baseline risk factors that the patient did present with were that a large proportion of them, or about half of them, had hypertension as a comorbidity, 14% had diabetes, and 7.1% of the patients had a previous MI. Of note, for the baseline medications that patients were on, a bulk of them were started on aspirin, as well as our P2Y12 receptor blockers. About 80% were started on ACE inhibitors or an ARB. For those that were studied with the beta blocker use in therapy, the ones that they did use were metoprolol and bisoprolol, with the majority of patients being on metoprolol. And finally, when we're looking at our lipid-lowering therapy, we do see that almost all the patients were on statin therapy. As we look into the results of this trial, the primary outcome, which once again is the composite of death from any cause of new myocardial infarction, we did not see that there was any significant difference in the primary composite outcome. When we look at our secondary outcomes, which are the ones that are following in the table, and the safety endpoints, they're also fairly similar between the two groups. Of note, the median follow-up for these patients were about 3.5 years, and 14% of those that have been assigned to the beta blocker group were actually taking beta blockers after 1 year of follow-up. Oral beta blocker therapy did not significantly reduce the risk of mortality or recurrent myocardial infarction in those with acute myocardial infarction, patients with preserved ejection fraction. And the incidence and severity of symptoms were similar after 1 year post-MI. And secondary outcomes in subgroups did demonstrate that there's probably unlikely clinical relevant difference between them. As we're looking into the strengths and limitations of this trial, we can see that the strengths of this trial include a large patient population, and with the regimens that were being followed, they did follow good GDMT. There was robust follow-up and data collection throughout this period. However, it does come with some limitations. This was an open label design, meaning that patients knew what they were taking, if they were taking beta blocker therapy or if they weren't. There was no assessment of types of heart failure hospitalizations, which may be able for us to distinguish better what's going on with the patients if they were to go back to the hospital. There's some limited generalizability of the trial, just because this was a study that was primarily conducted in Europe. However, it was multi-center, so they did have some practices, but it's hard to extrapolate that information into our own practices. And there was a high crossover rate of 14%. So again, they did find out that after 1 year of follow-up, that 14% of the patients that were not on any therapy were actually found to be on beta blocker therapy. Oh, Luis, you were muted.
Thank you, Stephen. Thank you, Stephen, for introducing that first trial. The second trial I'm going to introduce you all is called beta blocker interruption or continuation after myocardial infarction. This study was performed by Sylvain and colleagues. It is also referred to as the ABYSS trial, so I will be referring to it as the ABYSS trial moving forward. The ABYSS trial, the objective of the trial was to evaluate beta blocker discontinuation or interruption in post-myocardial infarction patients. This was a multi-center, open-label, randomized, non-inferiority trial conducted in France. The trial included a total of 3,698 patients with a post-MI left ventricular ejection fraction greater than or equal to 40% and an acute MI greater than or equal to 6 months prior to enrollment. The primary outcome of the trial was the composite of all-cause death, non-fatal MI stroke, or hospitalization for any cardiovascular reason. Looking at key baseline characteristics, we see that the majority of patients were above age 60. The mean age of patients was 63.5. Majority of patients were male. Majority of patients also had a history of STEMI with 37.7 with NSTEMI. The vast overwhelming majority underwent PCI at 95%. The risk factors that were noted were diabetes, 20.2% of patients, stroke TIA history, and 19.7% were current smokers. When looking at the medications that these patients were taking, we see that majority were on ACE inhibitors. They did undergo reperfusion with antithrombotics or were prescribed antithrombotics, which is standard GDMT, as well as lipid-lowering therapy. However, when we're looking at the beta blockers, 71.5 were on bisoprolol, 8.7 on atenolol, and so on and so forth. It is important to note that the vast minority of patients in this trial were on carvedilol and metoprolol therapy, as we are accustomed here in the United States. So the underwhelming minority were on these agents. So take the results of this trial with caution, mainly because the medications that were used to assess this to assess patients in this trial are not the medications we currently use, at least not the majority, at least not in our practice. When looking at the results of the trial, the primary endpoint, for the primary endpoint, the difference did not meet the criteria for non-inferiority. For the main secondary endpoint of quality of life, which this study did actually take into consideration, unlike the previous study, there was no significant difference in the mean European quality of life 5 dimensions questionnaire. The authors did conclude that discontinuing beta blocker therapy in this patient population did not demonstrate safety in terms of clinical events, nor did it improve quality of life. As far as the strengths of this trial, it did contain a large patient population. There were lower crossover rates than in the previous trial, and they did include the quality of life assessments. As far as limitations go, this was an open label design. It was conducted in France, therefore limited generalizability to our population here in the United States, and there was no stratifications of outcomes based on left ventricular ejection fraction. Less crossover means less bias towards non-inferiority hypotheses, and comprehensive follow-up data really helps with obtaining more information on our patients. Moving on to a study by Joner and colleagues titled Safety of Beta Blocker Discontinuation After Acute Coronary Syndromes with Preserved or Mildly Reduced Left Ventricular Ejection Fraction. The Joner and colleagues trial did include a total of 2,077 patients with an LVEF of greater than or equal to 40%, and who were prescribed a beta blocker at discharge. The primary outcome was a 5-year post ACS risk of MACE, which was a composite of cardiovascular death, stroke, TIA, myocardial infarction, unplanned revascularization, or hospitalization for unstable angina. When looking at the key baseline characteristics for this trial, we can see that the mean age of patients was 62.6 years old, 79.3% were male. As with the previous trial, majority of patients landed on an STEMI diagnosis or NSTEMI at 42.5%. Overwhelming majority underwent PCI as well. As far as the risk factors that were noted, a little bit more smokers in this trial. 51.5% had a diagnosis of hypertension, 15.9% had diabetes, and 11.6% had a prior MI, which is also different than the previous trial. Medications at enrollment, which was defined as 1 year after the index ACS that was being studied, are listed here for you all. One thing to note from this trial is that just like with the previous trial, patients were on adequate GDMT or guideline-directed medical therapy. When looking at the results of this particular trial, we see with the primary endpoint, there was no significant difference between discontinuation and continuation groups. This was also seen with the adjusted hazard ratio. As shown on the table, the secondary outcomes of all-cause death, cardiovascular death, or MI, non-CV death were also insignificant. Of note, there was a subgroup analysis in this trial that suggested potential harm in STEMI patients with the discontinuation of the beta blocker. The study concluded that discontinuation of beta blocker therapy within 12 months after acute coronary syndromes in patients with an LVEF of greater than or equal to 40% was not associated with an increased risk of major adverse cardiovascular events compared to continuation of therapy. However, the subgroup analysis did indicate a potential increased risk for our STEMI patients, suggesting that the decision to discontinue beta blocker therapy should be individualized, taking into account the type of ACS and other patient-specific factors. And of course, talking about the strengths and the limitations of the trial, when looking at the strengths, this cohort was well characterized. It did employ robust statistical adjustments. It had a long-term follow-up of 5 years post-ACS. As far as the limitations go, there was limited causal inference. There was a small sample size for the discontinuation group, and there was missing data and high crossover rates in this trial. And in summary, beta blocker discontinuation within 12 months post-ACS appears safe and was not associated with an increased risk of MACE compared to long-term continuation 5 years post-ACS. Of course, we must always take extra caution with our STEMI patients.
So, since we kind of did take a little bit of time just to go over all 3 trials, let's take a moment just to summarize everything. So in the first trial that we were talking about, also known as the Reduce AMI trial by Indigenous and colleagues, they did see that beta blocker continuation did not reduce mortality or recurrent MI risk in those with preserved ejection fraction. There were similar incidents of severity of symptoms in both study groups 1 year after MI.
The Sylvain and colleague study, we see that beta blocker interruption did not meet non-inferiority for the primary endpoint. There were no differences observed in death, MI, stroke, or patient-reported symptoms. With Joner and colleagues, we see that beta blocker discontinuation within 12 months post-ACS was not associated with an increased risk of MACE. There is potential harm in discontinuing beta blocker therapy in our STEMI patients.
So taking all that into consideration, Luis and I kind of came up with a general algorithm just to have a general guidance. However, I would take this with a grain of salt just because we don't have any other further guideline recommendations. This is a kind of a gray area that we're still trying to navigate. And of course, there's still some more evidence that we need to take into consideration. But what we concluded with was that if a patient has their first event of the myocardial infarction, we start them on beta blocker therapy once the patient stabilized, and then we titrate as they tolerate it. So at the 1 year follow-up, depending if they have a STEMI or an NSTEMI, we kind of differentiate them between the ejection fraction of the patients. So if their ejection fraction is less than or equal to 40, regardless if they're an NSTEMI or STEMI patient, we should follow our heart failure GDMT and reassess. So this means that we start patients on either metoprolol, succinate, bisoprolol, or carvedilol. In our NSTEMI patients with an ejection fraction of 40%, greater than 40%, it may be pertinent or it may be relevant depending on the patient factors to discontinue beta blockers if there's no other compelling indication. However, when we look at the flip side, in our STEMI patients 1 year follow-up, if they have an ejection fraction greater than 40%, we have to assess the risk versus benefit of discontinuing beta blocker therapy. Again, that last study did mention that patients with STEMI did experience more symptoms after discontinuing their beta blocker.
I would like to note as well that we are in no way are we endorsing that this algorithm for the use for its use in practice. We're just simply creating some sort of guidance based on the evidence that was found in the trials. And finally, bringing it back to the mayor of Townsville, patient MT. I would like to remind you all that he was admitted for STEMI and was started on guideline-directed medical therapy. However, he does not want to take all of his medications forever. How long would you recommend continuing metoprolol succinate for a patient, assuming he doesn't want to take his medication after a year, and assuming that we've already discussed the risk versus benefits, and you guys told him, hey, this is what was found in trials. However, decision is yours, and we're discussing it. What would you guys recommend? Okay, so 1 year. That is what we're going with today. Thank you for participating. The mayor of Townsville now has more insight about his beta blocker therapy, and we couldn't have done this without y'all's help.
So, because of the trials that we were discussing with today did have their limitations, there are some trials that are up and coming. Actually, two of them are estimated to be completed sometime this month. So we have the reboot trials, the Dan Block Beta MI trials, as well as the Smart Decision trials. As we can see, there's a different populations for each group. There are fairly great number of population for each one of them. They're looking at patients with more so like preserved ejection fraction or more of an mildly reduced ejection fraction as well. That did have either an STEMI or NSTEMI or just a myocardial infarction. But in the Smart Decision trial, they are looking at beta blockers at least 1 year or more. All of their outcomes are based on mortality, recurrent MI, or in some patients, or in some of the studies, um, heart failure hospitalization. So these are just some studies to keep in mind, just so then they may provide us some better insight and guidance, and may also affect our guideline recommendations.
Alrighty. Now that the mayor is feeling much better, he brought his secretary, Sarah Bellum, and wanted to ask you all a few questions. So, moving on to question number one.
So question number one, how do beta blockers improve outcomes in post-myocardial infarction patients with reduced ejection fraction? So those with an ejection fraction less than 40%. A, reducing myocardial fibrosis and promoting cardiac remodeling. B, lowering heart rate, reducing myocardial oxygen demand and improving ventricular filling. C, directly enhancing the contractility of the myocardium, or D, increasing the release of norepinephrine to sustain cardiac output? Correct, you guys. Good job. So it is answer B.
Moving on to question 2. According to the most current guidelines available, beta blockers are recommended in what subset of post-MI patients? Is it A, all patients indefinitely, regardless of left ventricular ejection fraction, only in patients with a left ventricular ejection fraction of greater than or equal to 40% and no other indications for beta blockers, patients with LVEF of less than 40%, heart failure or arrhythmias requiring rate control, or D, in all patients regardless of LVEF for up to 6 months? Yes, it's going to be C. Patients with an LVEF of less than 40%, heart failure or arrhythmias requiring rate control. Moving on to question 3.
Question 3. Based on recent primary literature, what is the evidence-supported duration of beta blocker therapy in patients post-MI with preserved ejection fraction? A, indefinitely for all patients with preserved ejection fraction. B, no longer than 3 months. C, discontinuation may be considered after 1 year if the patient is stable and event-free. Or D, beta blockers should not be used in patients with preserved ejection fraction. ICC. That is correct.
And finally, closing off with a patient case. This one much shorter. MJ is a 58-year-old male that was recently admitted after reporting chest pain and was diagnosed with a STEMI. His ECG showed LVEF of 55%. Subsequently, a stent was placed due to 85% proximal to mid stenosis of his left anterior descending artery. Which of the following is an appropriate treatment regimen for MJ given no contraindications to beta blockers? And I apologize, it was echocardiograph, not EKG. Is it A, we initiate metoprolol succinate at 50 milligrams once daily and continue indefinitely? B, initiate metoprolol succinate 25 milligrams once daily and reassess use after 12 months? Avoid beta blocker due to lack of evidence in patients with preserved left ventricular ejection fraction? Or D, we initiate beta blockers only if hypertension or arrhythmias are present? Yes, and then we get B. Exactly. We're going to initiate metoprolol succinate, 25 milligrams once daily, and then we'll continuously reassess.
Alrighty. Well, special thanks to our preceptors, Drs. Kayla Kraft and Dr. Erica Torres, as well as our University Health Pharmacy leadership for supporting us throughout this endeavor.
Thank you all for being here as well. And the floor is now open for any questions that may come up in the chat, or feel free to unmute your microphones. Thank you all so much.
Thank you, guys.
Alrighty. I did have a question for those of you that are still on. Um, this is more so like what you guys see in practice, because you may or may not encounter it whenever you're in clinic. Have any of you guys had to have the discussion about beta blockers or like discussing about side effects of beta blockers for patients that have been post-MI?
Yes, for sure. Especially if patients like never followed up with a cardiologist after the event, it definitely comes up. Yes.
Alrighty. And are there usually any issues during that time, or are patients still having any sort of symptoms?
Usually no symptoms, that are like related to anything that I feel like that would be specifically caused by a beta blocker. Like if they're having symptoms, it's kind of like a stable angina type thing. That's kind of what I've typically seen.
Gotcha. Yeah, thank you so much for the insight.
I think if anything, there could be some like confusion of whether to start them on metoprolol versus carvedilol and kind of that decision. But I mean, typically we're able to follow pretty good guidelines for guiding that or directing that.
Thank you for the insight. Yeah, I know there's so many beta blockers that are out there, and even in the earlier studies, they looked at timolol and a few other beta blockers. Um, I just think that when having that discussion, of course, carvedilol can also cause hypotension, due to its lack of selectivity to the beta one. But in any case, when using all three agents or either of the three, bisoprolol, carvedilol, metoprolol, succinate, I think that would be a good start. Just because if God forbid the patient progresses to heart failure, then they're kind of already on that therapy, and we don't have to switch them over to another agent or to the heart failure agent. Um, but yeah, it's definitely a good conversation to have overall.
Thank you for that point. I'll keep that in mind. That's helpful. Thanks.
Thank you. We did modify it a little bit. We had a little bit, I guess, a little bit more cheese on it, but we wanted to just kind of focus on the clinical aspects of it. But we definitely, previous presentations, we wanted to add a little bit more, or we added a little bit more spice to it, but we just kind of kept it simple, straight to the point, including some of the elements of that we all grew up with.
Alrighty, if there's no further questions, thank you for joining us. Again, I believe they did provide the attendance code in the beginning of the meeting. So thank you for joining.
Yes, for Alice Kim, thank you for your comment. Yeah, no, I definitely agree that so these studies essentially, like Stephen mentioned earlier, they came about because, we were just it was a blanket statement, hey, continue indefinitely. And that's how I was taught in pharmacy school about 3 years ago. So that was just what we would get taught and what was there on the guidelines. Now that we are seeing patients improve their heart function with these reperfusion therapies, that is kind of where these people that came to that realization, hey, let's study beta blockers now that we're salvaging more of the um, cardiac tissue. Now that we're salvaging it more with reperfusion therapies, let's go ahead and study beta blockers again or revisit that topic. And so hence why like kind of resurfaced in recent years. So it's very interesting that we're now getting all these trials that are looking more at it. And I just want to point out that a lot of these studies are registry based. So although they are randomized, some of these are registry based just because of the ethics of it all. We don't want to just because we don't know there's a big gray area. We don't want to just throw patients into the hey, let's stop your beta blocker. So these are registry based studies. So that's where a lot of the bias can come in. That's where a lot of the continuation of a gray zone, we don't really know what to do, continues because of registry based, but I'm sure that with these upcoming trials, two of them that are going to be published hopefully this month and one later this year, we'll have more insight, and hopefully the AHA-ACC can give us more guidance in the future. Thank you. Thanks everybody.